All right, thank you guys for coming. Again, this is Dr. Linville. This is elbow differential diagnosis for MSK1. Let's see if we can get this thing fired up here. So with elbow differential diagnosis, much like the shoulder, there's a couple of ways that we can figure out the best way to bucket some of the diagnoses that we're trying to uh, uh, differentiate, right? Differential diagnosis. The two main principles that I use are something called quadrant sectioning. It's something that I've termed over the years, and then tissue type. And so, of course, tissue type is going to be things like contractile tissue, inert tissue, or nervous tissue. And just to kind of put into your head, these are the things that I think about whenever I am tasked with a new evaluation of a patient and I'm trying to figure out where I need to go in my exam to best serve the patient. So the quadrant sectioning we'll see on the next slide is going to help you determine location, right? Because we know location helps us differentiate between a medial or lateral sided problem. And then the tissue type is going to help us determine what type of exercise maybe to do or interventions to do to help with it. If it's contractile, meaning tendon or muscle, our exercise selection or treatment selection is going to look a lot different than if it's a nerve type of injury. So those are the two main principles, and you can use those across the board in other types of uh, differential diagnosis, other types of the body as well, other sections of the body. So let's get into it. This is an example of quadrant sectioning. As you can see, what I've done in this circle here is I've taken the four kind of main directions of the elbow: anterior, medial, posterior, and lateral. And I've bucketed in the differential diagnoses seen in those specific areas to help me when I get a patient whose subjective reports say something like, I have pain on the inside of my elbow versus pain on the outside of my elbow versus pain on the back of my elbow. I've now already eliminated some of the differentials. If they say medial sided elbow pain, I'm not going to be thinking of symptoms of lateral sided elbow pain. And so this is where, there is some nuance with that. So, but not to muddy the water, we're going to, in this course, really teach you, a problem on the inside of the elbow is probably due to the tissue that's related to the inside of the elbow, and so on and so forth. So I want you to try to think about this. Now, if we go back to the shoulder doesn't have an anterior, posterior, medial, and lateral. There's no medial, right? So there's actually anterior, posterior, lateral, and superior of the shoulder. And the superior would encompass things like the clavicle, the AC joint, things like that, right? Maybe a slap tear. And so those are, different areas of the bodies might warrant different types of quadrant sectioning, but it's still good to try to bucket these. And that's how my brain works with some of this stuff. So I thought I'd share that with you. Tissue type considerations, again, the other principle I use, these are examples here: contractile tissue issues of the elbow, inert tissue issues, and nervous tissue issues. So we're going to try to go through many of these today. Well, lateral epicondylalgia is our first one, and guys might know this better as tennis elbow. Some of you might have had this, or your parents may have had this. The age, in terms of what patients get this, is going to be 35 to 50 years old, with females slightly more than males. Morphology is going to be usually someone's dominant arm and involves the muscles that control the wrist into extension and radial deviation, and even some supination for that matter. Past medical history is going to be repetitive overuse, and if we'll see this usually in people with spikes in workload. So let's say it's that New Year's resolution person who hasn't worked out in a while. They want to get back in shape. They go into the gym. They work out. A couple weeks later, they're having this lateral elbow pain. Also in laborers and things like that. So the pathophysiology is that macro or micro tears occur in the common extensor tendon due to repetitive overuse with the wrist positioned in extension or repetitive extension type of work. So any of the muscles that attach onto the lateral epicondyle, repetitive overuse of those muscles can cause this condition. So you're going to, with subjective reporting, that they're going to complain of pain in the lateral elbow. They're going to point to the lateral epicondyle or just distal to that into the common extensor tendon. Some people have proximal to the lateral epicondyle, but generally the lateral elbow is going to be the source of their most pain. They're going to have reports of gradual onset of pain after a spike in workload, and they can report chronic history like quote unquote, I thought that this would just go away on its own, but it hasn't. And they're 3, 6, 9 months down the road and they haven't found really any relief. And physical therapy, they finally went to the doc and they got sent to physical therapy. So you might have someone who has a chronic condition. Objectively, you're going to find that they have pain to palpation at the lateral epicondyle or the common extensor tendon, and that tests like the Cosen's test, Mills test, and Maudslay's test are all going to be positive, or maybe a few will be positive, a few won't, but you're trying to collect a cluster of tests that help you determine this differential diagnosis. The Cosen's test is right here. You can see that we're doing resisted wrist extension. And the Mills test is here, passive wrist flexion, because we're putting tension through the muscles of the lateral elbow. And then Maudslay's test is a resisted third digit extension test. So these you're expected to know in more detail, especially during our practical week, our intensive week, we're going to go over these. So start learning them now. As we can continue on here, we're going to talk about medial epicondylalgia. Again, also known as medial epicondylitis or golfer's elbow. This is going to be people from the ages of 12 to 80 years old, but I want you to hear me clearly. The most common is in the 4th and 5th decades of life, just like lateral epicondylalgia. We are going to see this in younger individuals, maybe older individuals due to specific work capacities, but such as athletes and things like that. And older people just might have a little more degenerative tissue. So just want to be aware that this can happen outside the 4th and 5th decades, but that's the most common. So if you get a case study, it's more than likely going to say 4th or 5th decade of life. And so be looking for that on any exams that you might do as well. In terms of gender, there's really not a difference. Males and females seem to be affected equally. And then morphology, again, dominant arm is more common. There's going to be pain at the medial epicondyle with wrist flexion and pronation. And ulnar deviation, and those are the opposite, of course, of what lateral epicondylalgia is. So if you need to try to bucket these and understand which muscles do which and where they attach, because medial epicondylalgia, everything that attaches to the medial epicondyle is going to be your wrist flexors and your pronators, and where on the lateral side it's going to be your extensors and your supinators. Okay, past medical history similar to that of lateral epicondylalgia. The pathophysiology here, again, is very similar to lateral, and that's going to be medial tension overload of the elbow associated with repetitive microtrauma of the flexor pronator mass, and that's going to affect its origin on the medial epicondyle. So it's essentially a tendinopathy here. As we continue on, see if I can move my little face around here. Subjectively, they're going to say pain is associated with activity, more so afterward. And sometimes the beginning of activity, but as they get warmed up, it feels better. But then afterwards, they have this rebound pain as well. Onset of pain associated with wrist flexion and or pronation activity. Sometimes we see this in people who are doing a lot of pull-ups, CrossFit, butterfly pull-ups, weightlifting, throwing, things like that. Pain with pinching, squeezing, and holding objects and wringing things out. The tests here are very, very similar to that of the lateral epicondylalgia test. You can see there's a resisted test, which would be medial epicondylitis test 1, resisting wrist flexion in a supinated position. You can also see that there's a passive test where we're going to take this person's wrist into wrist extension. Right? I don't know if you can see me on the video, wrist extension. And then, so we're stretching those tissues passively. And then finally, a resisted pronation test. So kind of like an arm wrestling test, seeing if we can elicit pain there. Very good. So let's move into biceps tendon injuries here. We're going to categorize these into two types of injuries. One's going to be more of a tendinopathy, a tendonitis, let's call it, distal tendonitis, and the other is going to be a traumatic rupture of the tendon. So this usually happens in 35 to 55 years old who gets bicep tendon injuries distally, males greater than females. Morphology, they're going to have pain at the anterior aspect of the arm. These are usually muscle-bound individuals. Past medical history, they may have had prolonged corticosteroid use from some sort of medical condition they had, or even anabolic steroid use, which we know degrades tendon integrity over time. Pathophysiology, there's two mechanisms. One is the tendinopathy from repetitive overuse and traumatic tendon rupture from high load eccentric contractions. And so if we think about distal bicep tendon injuries here with subjective reporting, with tendinopathy, they're going to have tenderness to palpation of the distal biceps belly, maybe the musculotendinous portion of the biceps or the bicipital insertion onto the radius. It's always important to palpate the radius insertion there. Pain is reproduced with resistant isometrics of elbow flexion or, more importantly, supination. Biceps brachii main function is to supinate the forearm. It's not to flex the elbow, even though it does assist in that. So supination, resisted supination is going to be painful. And then in a tendon rupture, we're obviously going to have a trauma. So objective findings here for tendinopathy, we're going to have pain with repetitive loading. We've talked about that. And then with a tendon rupture, we're going to observe things about this. So it's a traumatic injury. So I want you to picture this. Someone, their bicep pops, let's call it. They're going to be a tremendous amount of pain. They're going to be holding their arm. You might notice that the bicep muscle recoils up. That's going to be called a Popeye sign. It's a bulge left by a deformed muscle. The palpation, you're going to palpate even a gap in the elbow from where the muscle has now recoiled up the arm. Manual muscle testing, supination strength is going to be very weak, and elbow flexion strength is going to be weak. Biceps hook sign will be absent. The bicep squeeze test will also be absent. And then there's diminished strength of elbow flexion and supination. Here are some pictures I wanted to show you guys of what this bicep tendon rupture looks like. You can see the picture on the left. You can see this Popeye deformity, this big gapping here, right? Here's another example how that Popeye deformity recoils the bicep brachii muscle up, still attached proximally, so distally it tears and it recoils up. And you'll see the bruising here along the anteromedial forearm and arm there. The biceps hook sign is very simple. We can flex our elbows and find our bicep tendon inside of this little gap here in the antecubital fossa. So you can stick your finger behind yours. You should try that now. And the bicep squeeze test is a very simple test. They're in a pronated position. You squeeze their biceps, and their hand should supinate a little bit as you squeeze the bicep. And so if they don't have supination with the bicep squeeze test, it may be a sign that they've ruptured it. So as we move out of tendons, we're going to move into ligaments. And there's a couple things we didn't touch on. One's a tricep. That's mainly the other things, the tricep tendon, but very similar mechanism as the bicep, but much less uncommon. So we won't be going over that in this class, but similar mechanisms and things like that. High eccentric load into elbow flexion while you're trying to resist it with the tricep, and that tricep can rupture as well. Bicep, much more common than a tricep injury. So we are going to stick with that simply today. As we move into ligaments and inert tissue here, we're going to talk about first the ulnar collateral ligament, or the UCL, as we call it. The patient that has these injuries is going to be someone between 14 and 40 years old. Males are affected greater than females. In terms of morphology, really overhead athletes make up predominantly a lot of these cases in the dominant throwing arm. Obviously, you can see the picture of the baseball player at the bottom, how much valgus stress is going through that arm as they throw. The UCL is the main resistor to valgus stress between 20 and 120 degrees of elbow flexion. So as they're coming through in their throwing motion, they get a ton of stress on the inside of the elbow here. And that ligament is one of the structures that helps prevent valgus, we should say varus torque, which is, we won't get into the biomechanics, but varus torque, you need things that help you keep you in varus to avoid valgus stress. The UCL is one of those things. The flexor pronator mass is one of those things. So make a long story short, the UCL is one of those primary restraints to valgus stress, and we're taking our arm through that position so many times as a thrower that UCL can become injured. The other sports that we see this a lot in are things like wrestlers, gymnasts, football players trying to plant their arm as they're running, right? People who fall from a height and land on their arm, they might get a little pivot shift in their elbow trying to brace for impact. So we're thinking things like trauma as well. Past medical history, again, usually an athlete outside of some traumatic event. In terms of pathophysiology here, I just mentioned it, repetitive valgus overload between 20 and 120 degrees of elbow flexion. This puts chronic strain on the ligament and can attenuate or stretch it out over time. Pain usually comes on more gradually with UCL injuries in throwers, but you can have a singular moment, a pop, if you will, but that's not as common in throwers. What's more common in those wrestlers and gymnasts and stuff is the pop, okay? the UCL also may be injured in frank elbow dislocations as well, because if the elbow is getting dislocated, a lot of the structures around the elbow will get injured as well. So here are some subjective reportings that you can do. And you'll ask some questions and they'll tell you that they have reports of medial elbow pain and difficulty during throwing, pain, laxity, and gapping with valgus stress test. They may report history of a pop, numbness and tingling into the hand because of the proximity of the ulnar nerve, difficulty with weight bearing, stiffness secondary to effusion. So objectively, you're going to find valgus stress test may be positive, limited elbow range of motion. They're going to be tender, maybe with direct palpation at the medial epicondyle or the sublime tubercle. And the moving valgus stress test and also the milking maneuver may be positive. And we see here in this picture, this is Todd Ellenbecker. He's a PT out in Scottsdale. He's doing a valgus stress test here. I would do it in a pronated position. We'll teach you guys how to do that. And then also here's your moving valgus stress test, which we take their arm into, a flex position, 120 degrees, and we slowly open their elbow as we apply a valgus stress. And this was defined first by a guy named O'Driscoll up at Mayo in my neck of the woods here in Minnesota. So what is Little League elbow? Little League elbow is a very similar diagnosis to UCL injuries, but it's in the skeletally immature population. We're going to see this mainly in 8 to 11-year-old baseball players or throwing sport athletes, and their growth plates are not fused yet at the medial epicondyle. You have a medial epicondyle growth plate. And so at that point in time, when you're young, the ligament is stronger than the growth plate. The growth plate is the weak link, if you will. So as you're throwing and you're getting all that valgus stress, the growth plate is where you'll get the injury rather than the ligament. So you'll probably see this term Little League elbow or medial epicondylar apophysitis. In the worst case scenario, what might happen is if they keep throwing through pain, these little kids, they can have an avulsion fracture and that growth plate can pop off and they may need a screw. And you'll see a picture of that later on from a surgical standpoint. So when we're thinking about Little League elbow, there's some risk factors. I want you to kind of memorize those risk factors down there at the bottom left of the screen. And the right side of the screen, you can see the picture of the fracture here. The growth plate has popped away from the humerus and they need to take a screw and screw that back on. What about fracture or dislocations of the elbow? Well, the patient age here, it's going to really be dependent on the type of fracture, but dislocations usually are in athletes or with Fuchs type injuries. Gender, usually males and females affected equally. A lot of this is just trauma, right? So wrong place, wrong time, unfortunately. Past medical history, people with bone health issues like osteopenia or porosis, smokers, risk takers, contact sport athletes. The morphology, several types of common fractures. There's fractures from like defense. If someone's getting into an altercation, they put their arm up, they might fracture their forearm because they're, defending themselves. You might have a kid who was skateboarding and fell off the monkey bars, lands on the elbow and breaks, the distal humerus. That's another type of fracture. You might have a radial head fracture from an old person who falls. And we'll show you examples of all those types of fractures. The point is for you to not to understand maybe the nuances of them, but that they are present and that it's something that you may see from a differential diagnosis standpoint. Pathophysiology here is that high force trauma to the elbow complex, either with a direct blow or a Fuchs-style injury, may cause a fracture or a dislocation, or both. There's something called a fracture dislocation. So you're going to use your quadrant sectioning to determine a likely differential diagnosis. Dislocations happen from a Fuchs-style injury with the arm landing palm down in a axial loaded position, but the arm's going to be supinated and slightly in valgus. And those three things, axial loading, supination, valgus positioning, may lead to an ulnar dislocation. It dislocates posterior on the humerus. So as we move on to the next slide here, well, what's subjective reporting? Well, they're going to have global elbow pain and swelling, describe a high velocity mechanism of injury, and unable to move their arm. And you can see at the picture at the bottom, that gentleman holding his arm, he looks like he's in the emergency department. As you can see, there's someone with scrubs here, but that ulna is posteriorly subluxed and it's stuck, it's perched, if you will. So we'll see a picture of an x-ray of that in a second. This warrants immediate medical referral to the emergency department or calling EMS and perform first aid emergency medical response as necessary as a provider. Objective findings here, you're going to check their neurovascular status, make sure they have good blood flow and sensation to their hand. Elbow extension test, you may put them through that to test for a fracture. Also for a fracture, you might use a tuning fork to see if that elicits any pain. They're going to have deformity mainly, traumatic swelling, and needs imaging once stable. Here are some examples of what's going on. Elbow dislocation, you can see the picture here. This elbow is posteriorly dislocated. Here's what it looks like in a closed fashion. If it's open, the skin would be open. Closed fractures or dislocations mean you cannot see the bone or blood or anything like that. The skin is intact. An open fracture or open dislocation is when the bone is protruding through. Elbow extension test, as you can see here, this person should be able to straighten their non-injured arm just fine. Their injured arm, if they cannot fully straighten it or fully bend it, but really straighten it, we're concerned about a fracture of the elbow. Elbow fracture, that's a closed fracture again, in a more of a pediatric patient. You can see this is a distal humerus fracture. You can see kind of this dinner fork deformity, we call it. And this may be a more subtle case here that you can't really tell that there's a deformity, but there is swelling, there's redness. And so what we have to do is we have to take their subjective into account to really make sure that we get them into the right medical provider's hands. All right, and as we continue on here, this is how the elbow dislocation happens. It's going to be max supination with axial loading and a slight valgus stress. And you can see that down the bottom left here is a reduced or normal elbow. Here's the mechanism, posterolateral rotary instability is the PLRI. And what's going to happen here is you're going to have supination, valgus stress, and axial loading. That's going to create this posteriorly direct force. Grade 2 is going to be a perched position, and grade 3 is going to be a full dislocation of the elbow. All these different sports, this happens. Like this is a traumatic event. This may even be a fracture dislocation because of the hyperextension here. This is certainly something very bad, and this person's elbow as well here. So this is what we're looking at if we're thinking elbow dislocation, unfortunately. As we move on, here's some examples of fractures. You can have fractures from all sorts of different trauma. We mentioned a few earlier. It's not our job to fix this. Obviously, it's the surgeon's job, orthopedic surgeon, but we're going to see these people after a trauma in rehab. So it's important to understand maybe what happened, what bones are involved, what vascular structures, what nerve structures may have been involved as well, so that we can rehab to the best of our abilities. So this is just a distal humerus fracture. There's many different types, and you can see the two pictures on the right is how they would fixate that. Here's that medial epicondyle fracture as well. Again, skeletally immature youth athlete. Even up to 12, 13 years old can have this happen, but 8 to 11 is the most common where we're seeing that they're having stress to this area. But as they get a little bit older, into early teenage years, they may throw harder. They may be more susceptible to something like this. Radial head fractures, you can see there's three types. There's a closed, simpler fracture. There's a displaced fracture. And then there's a comminuted fracture, which is that type 3. And so you can do anything from fixate with screws and plates all the way up to that bottom right picture here of having a radial head arthroplasty or a radial head replacement, if you will. Here's an olecranon fracture. Again, maybe you land on your elbow from a height and you fracture your elbow right at the tip of the elbow there. So you can fixate that with screws. Here's a coronoid fracture, another area of the elbow, again, fixated with screws and plates. Here's something called a Montesia fracture. Again, you're not going to have to memorize the names or things like that, but these are just different examples. This is a fracture of the ulna with a dislocation of the radial head. So whatever trauma is coming in, right, so much trauma, force coming in through the ulna, all that force goes through and actually dislocates the radial head as well. So as we're moving on here, what about osteoarthritis of the elbow? We've talked about that in the shoulder. We're going to talk about that, of course, extensively in the knee and the hip and the ankle, because those are weight-bearing joints. But what about the elbow? When MSK2 comes around, we're going to talk about all those all the OA things in the lower extremity, but does it affect the upper extremity much? We talked about the shoulder, so yes, it does. But let's go over the demographics here. So age, usually these are going to be people 65 and older. Okay, so my slide here says 40 to 60 years old, and then also says 65 plus. But let's be clear, OA affects people that are older, generally 65 or older. But people with a history of strenuous work or a history of trauma may have earlier onset of osteoarthritis, and that's true for all joints of the body. We're thinking people like um, maybe former athletes that were college or professional athletes that have a lot of wear and tear on their body. We're thinking of people with heavy weightlifting over years and years and years. We're thinking of people who were maybe injured in combat in the military. They have post-traumatic arthritis, things like that. So just know, generally speaking, OA is going to be older. You guys know that by now. And don't get confused by that on my slide. I just want to make a point that sometimes we'll see it in younger individuals as well. Gender, we're going to have equally affected here. Morphology, all different types of morphologies. Past medical history, maybe they have past trauma to the elbow. In terms of pathophysiology, arthritis of the elbow may result from numerous different conditions, including trauma, rheumatoid arthritis, crystalline diseases, infection, osteoarthritis, etc. But we'll focus on OA. They all present with pretty similar impairments, but OA usually affects weight-bearing joints, making elbow one of the least common areas for osteoarthritis, which is a good thing. Here's an x-ray of what it will look like, and this is how you would truly diagnose this. You'd have a constellation of symptoms: loss of motion, morning stiffness, general loss of strength, maybe pain, things like that. You're going to have maybe a hard end feel earlier in the range of motion. An x-ray would confirm some of this through, as you can see, some of the osteophyte formation and decreased joint space. Subjectively, they're going to have complaints of diffuse pain, loss in range of motion. They may state that there's grating or locking sensation in the elbow, pain with ADLs, difficulty lifting and reaching. Objectively, you're going to find stiffness and range deficits. You might want to do varus and valgus stress testing. You might want to do some of the epicondylitis tests as well to see what their symptoms are. But really, plain radiographs or x-rays are going to be the main source of how you diagnose this. And then you're coming up with a treatment plan to try to improve their stiffness, improve their weakness, etc. We're going to move into our last section here. We have 3 more diagnoses, so stay with me. We're going to talk about compressive neuropathies. This is something we didn't talk about much in the shoulder, but we will talk about in the hand because the elbow has many neurovascular structures running through it, and we're going to talk about some of those neural tissue structures as well. So you need to memorize this slide and the pictures of the hand because this is going to show you where the nerve distribution is. And if we have a test question that says, hey, someone has 4th and 5th digit tingling and burning, that clues you in right away to maybe what nerve or nerve root is affected, and it can help with your differential diagnosis decision making. So let's talk first about cubital tunnel syndrome. Cubital tunnel syndrome is mainly seen in people that are age 40 to 60 years old. In terms of gender, we're going to see this 4-to-1 ratio females to males. Males, though, it's going to be greater in overhead athletes because of baseball players. This nerve gets tractioned a lot with valgus stress, so you're going to see it more in baseball players as well. But the morphology, this is going to be the second most common peripheral neural issue, neuropathy, behind carpal tunnel syndrome. We'll get to carpal tunnel in the wrist later this term. Desk workers and overhead throwers are the 2 main types of people who get this. People with diabetes type 2 also may be at a higher risk because they're higher at risk for any nerve type of issue. Pathophysiology here, it's going to be compression, traction, valgus stress of the ulnar nerve at the cubital tunnel of the elbow. That's where your funny bone is. That's between the tip of the elbow, the olecranon, and the medial epicondyle. The ulnar nerve runs right in between. So if you want to test this, go bang that on your desk, and you'll get tingling into your 4th and 5th digits, and you'll see how these people feel. You also may have this, you can see this when you sleep at night and your arm's in a funky position and your elbow's bent for a really long time. You may wake up and you have like, oh, it's hard to move your hand. It's all numb. It's like you don't even want to move it. Well, you might have been putting compressive force through your ulnar nerve, which has led to that. And then after a minute, when you get out and you move your elbow, all that tingling goes away because that nerve becomes decompressed. Subjectively, they're going to complain of night pain, as I just said, numbness, tingling. So if they're sleeping, cuddled up and their elbows bent, they're going to complain of night pain because they're going to get compression through that nerve. Ulnar-sided sensory changes, clumsiness, hand weakness, okay? All these things that you'll see intrinsic muscle loss of the hand, as you can see in the picture down here. You'll see something maybe called claw hand deformity here, or Bishop's deformity. Objectively, you're also going to see that the elbow flexion test may be positive. They may have a positive Wartenberg sign or a Froment sign, and they're going to have weakness of the muscles listed here. The elbow flexion test is pretty simple. You're going to have the patient flex both their elbows and then extend their wrists. The picture doesn't show the wrist extension. You can also go extend the fingers. You're going to hold this position for as long as they can either tolerate it or up to 3 minutes. You're going to see if they have tingling and burning and numbness reproduced with that test. That's a sustained hold test. The Wartenberg sign, the picture at the top right, you can see that pinky, they cannot adduct that pinky on the right hand. That's a positive sign. And then the Froment sign is going to be more of a grip test. So with the pinch grip, which is the picture on the left, that's going to be more of an ulnar nerve-driven motor control test. If you pull the paper away from them, their thumb may drop into this flattened keypad hold grip, and that's going to be more median nerve helping with that. So if they cannot sustain it, they may have an ulnar nerve issue. Let's talk about pronator syndrome next. This is going to be overuse injury of the forearm from neuropathy of the median nerve as it gets compressed as it passes through the humeral and ulnar heads of the pronator teres. So it's a pronator type issue. The median nerve runs through the pronator teres. With too much stress or hypertrophy of the pronator, you may get this type of injury. Age greater than 40, women greater than men, desk workers again, and younger athletes that require a lot of flexion and pronation, like gymnasts, for instance, they may get this. And again, past medical history may be someone with type 2 diabetes. You can see this is one of the tests that we do for this. We're going to palpate and compress the pronator teres, supinate the forearm so that we have the pronator on stretch, and then extend the wrist so we tension the median nerve. And you can see all of those things will put compression or tension through the nerve, and they may reproduce symptoms. They're going to complain of pain and paresthesia from the anterior forearm exacerbated by applied pressure to the pronator teres. Nocturnal pain is uncommon in these individuals. This is mainly with working or resting your arm on stuff. So working meaning the muscles are working, right? The pronator's working. Carpal tunnel is a median nerve injury. That night pain is very common. Pronator syndrome is a median nerve injury where night pain is uncommon. So that's a way you can differentiate because both will show symptoms in the hand. It's important to know the difference between those two. Again, the lateral aspect of the hand is going to be numb, tingling, etc. You may have reduced grip strength from some of the motor control loss if this is progressing. Some objective findings, Tinel sign may be positive. The Phelan maneuver, which you'll learn in carpal tunnel, will not provoke symptoms. So again, a carpal tunnel compression test will not provoke symptoms. It has to be more up the chain, right? So that's where the tests below come into play. Palpating the pronator teres, Tinel sign to it, activating the pronator teres, stretching it, compressing it. These are all things that might reproduce symptoms, okay? One thing I do have a typo is this last bullet, symptoms with resisted supination of the long and resistance of the long finger flexors. This should actually say pronation. Symptoms are reproduced with resisted pronation. So there's a typo there. I apologize for that. And then our last thing here is going to be radial tunnel syndrome. Radial tunnel syndrome. As you can see here, it's going to be people aged 30 to 50 years old, women greater than men, desk workers and laborers. Type 2 diabetes is a past medical history. There's many areas where the radial nerve can come entrapped and compressed, but one of the ones I want you to understand is the one on the posterior humerus in the radial groove, right? That's an important thing if they have a fracture to the humerus. You're going to want to make sure that they have radial nerve sensation. As we move along here, subjectively, they're going to say that they have burning and aching in the the dorsal forearm exacerbated by repetitive activity with uh, pronation and wrist flexion activities, using a screwdriver, typewriter, typewriter, right? Screwdriver, keyboard, computer keyboard, or during handwriting. Pain is reported over the anatomical snuff box with the dorsal thumb, and then grip strength and weakness due to pain if this has progressed. The radial nerve is usually a sensory issue. Usually, if you have a certain kind called a posterior interosseous nerve issue, which you can see dives deep, you may get some motor function impairment as well, but usually it's going to be more sensory. So the motor, anything that's more motor unit affecting is going to be more serious of a condition. Objectively, you're going to want to do dermatomal testing, motor testing to the radial nerve, what the radial nerve innervates, and Tinel's test or compression, and attempt to elicit the neuropathy. Thank you guys for joining me. I appreciate your time, and shoot me some questions if you have any. Thank you very much.